Hello, and welcome to the Pharmacy Symposium titled Highly Effective CFTR Modulators in the Post-FDA Approval World. We're excited for you to join us today. My name is Rebecca Pettit. I'm the Pediatric Pulmonary Clinical Specialist at Riley Children's Hospital in Indianapolis, Indiana. And on behalf of myself and my co-moderator, Brittany Wright, we are excited for you to join us today. I have no relationships to disclose with regards to this presentation. So my job today is really to give you an overview. So we know Elexacaftor, tezacaftor, ivacaftor is one of our highly effective modulators. It was originally approved for those 12 years of age and older in October of 2019 and was very recently approved down to 6 years of age in June of 2021. We know about that information in the package inserts and the information from the drug studies, but really what we're going to explore today are those real life issues and questions that we are dealing with in our clinical practice. So we'll start out with Brittany Wright kicking us off with real world management of adverse effects of highly effective CFTR modulators. So this will be more than just what's in the package insert, talking about those side effects we're seeing as we use this medication in more patients and what people are doing from a management standpoint. Next, Michelle Simonson will talk to us about interaction intersection when highly effective CFTR modulators meet other necessary therapies. So we're definitely running into this in clinical practice as we use these modulators in more patients. Then Sabrina Sherwood will talk about Baby on Board, treating pregnancy and lactating women with highly effective CFTR modulators. So something we're definitely seeing more of is the increase in pregnancy. And so this is a hot topic in many centers. And then our final presentation that I'm very excited for is Jillian Mozak, who is a person with CF. We'll talk about her personal journey, why on modulators, and talk us through some of the things she's been through and how us as a care team can better support our patients. So thank you for joining us, and we look forward to these great presentations, and feel free to ask any questions you have during the Q&A session. We're happy to have a great discussion.
Hello, everyone. My name is Brittany Wright, and I'm a clinical pharmacy specialist at the University of Iowa Hospitals and Clinics. My primary practice site is both our pediatric and adult cystic fibrosis center. Today, I will be discussing the real-world management of adverse effects associated with highly effective CFTR modulators. I have nothing to disclose for this presentation. And before we get started, I wanted to make a brief comment about the references I'll be using for today's presentation. I certainly will reference the Vertex Pharmaceuticals Tricafta package insert often, and also some of the primary literature when available. However, I think most of us know that a lot of the adverse effects we're seeing aren't necessarily published on yet. So I'll also be documenting conversations that have occurred on the pharmacist listserv, as well as just what we're seeing in real life. And then I included a little statement of all the different ways I will be discussing triple therapy and how I'll be documenting that on the slides. This is going to be the general template that I use for all of the adverse effects that we discussed today. On the left-hand side, you're going to see the prevalence as well as the clinical presentation. And on the right-hand side, you're going to see some management strategies that we can use to hopefully treat or avoid the adverse effect. So let's go ahead and get started. Our first adverse effects is going to be headache or migraine. This occurred in about 17% of triple therapy patients compared to 15% of the placebo group. This occurred as dizziness, eye pain, nausea and vomiting, as well as sensitivity to light. And when we flip over to management strategies, one of the most common ways to start when you're dealing with this problem is simply to flip the morning and evening dose. And we have actually seen patients have a response to this. So instead of taking the orange tablets in the morning, go ahead and doing blue in the morning and then orange at night to see if that makes a difference. Something as simple as using an over-the-counter pain reliever, such as acetaminophen or ibuprofen, can certainly be helpful, as well as adequate hydration. Now, if you still aren't getting an effect with any of those options, it is reasonable to consider a dose reduction, temporary, of course, and then building back up with a titration if those headaches resolve. Sometimes patients just get lucky and it does resolve after 7 to 14 days on its own, with or without any of these management strategies. I did put a few asterisks in here because I think it's important to note, and we'll certainly be discussing a little bit more of this later, but you don't want to just assume the headache is Tricafta related and wanting to evaluate other options that it could be, so including hypertension, allergies, or vision. All right, next up, we'll talk about constipation. So I will tell you that these percentages that I have pulled from the peggage insert were linked under abdominal pain. So 14% of patients starting triple therapy did have abdominal pain compared to 9% in the placebo group. Now this could be abdominal pain, cramping, or just overt constipation. And really our gold standard for treatment is going to be a polyethylene glycol or a clean out. Some patients will require therapy interruption. However, I would say not all centers will automatically stop the triple therapy. They may just treat that constipation and push through. It does tend to resolve quickly with those clean out procedures. If needed, if the constipation does persist, temporary dose reduction with further titration is certainly an option as well. And we've had some centers that have tried to decrease enzymes. You know, I think this is a really hot topic that we're seeing at CF centers and the benefits of triple therapy. But some centers have utilized this approach in the setting of constipation and found it helpful. All right, next I'd like to discuss the rash that we see with triple therapy. So about 10% of patients did develop that rash 1 to 2 weeks into therapy versus that 5% in the placebo group. Now, it's important to note that this rash is quite variable. So it can be localized, it can be full body. It may or may not include itchiness. Initially, we thought this was hormone related, but definitely in this population with pediatrics now being involved and then the longer use of triple therapy, we're seeing that that's not always necessarily the case. In terms of treatment strategies, really oral antihistamines, steroids, and then H2 receptor antagonist are going to be our best approach to try to treat that rash. Once again, if therapy interruption is needed, that's always an option. But if patients are able to kind of push through that rash, it is usually going to resolve on its own within 1 to 2 weeks. So really symptom management as long as they're able to continue the medication. Now, certainly that's not always the case. And we have a couple publications from our colleagues at the University of Kentucky who have discussed desensitization protocols. And so how they've been able to work on dosing to actually allow patients to remain on triple therapy when they do develop that rash. And it would seemingly be rate limiting for continuing. All right, next I'd like to discuss isolated hyperbilirubinemia. So this was documented in about 5% of triple therapy patients versus 1% in that placebo group. Now you'll see here that the clinical presentation is very brief, and that's really because the only lab monitoring that we see is that increase in indirect bilirubin, and oftentimes that's not clinically relevant. So when we switch over to the right side of my slide here, you'll see the word consider a lot. And it's really because this is a tricky thing to manage because we don't always know the best approach if something isn't clinically relevant. So one thing that you could consider would be genetic testing for Gilbert syndrome. And we will talk about this in some of the other presentations in this section. But also consider increasing LFT monitoring, making sure you're looking specifically at that bilirubin level and not just always the AST and ALT. One thing you could consider is doing the hepatic dosing adjustment that we see for Child-Pugh class B, so that altering of 1 and 2 of the triple therapy tablets every other day, and see if you still see that elevation, or if you're able to continue on therapy without any concerning LFT changes. And then lastly, you could always consider that liver ultrasound and referral to hepatology, just to make sure there's no underlying liver conditions. Now, colleagues at the University of Pennsylvania and Johns Hopkins actually reported on a couple of patients. It was a total of 7 that had those biliary complications after starting triple therapy. And several of their patients did require intervention. So I think it's something that we need to definitely understand more about and not just play off as always being clinically irrelevant. All right, next I'd like to talk a little bit more about hypertension. So I mentioned this on our earlier slide when we were talking about headache and migraine. And this did occur in about 4% of patients versus that 1% in the placebo group. So nothing surprising here. We can see that increased blood pressure when measured, as well as those headaches and blurred vision. The easiest way to kind of assess this is looking at home blood pressure monitoring. As we know, white coat hypertension can definitely occur when our patients are coming to clinic. We don't have strong guidelines yet for the use of antihypertensives in CF. So right now that does revert back to just standard blood pressure guidelines and management. However, you could also consider dietary salt reduction, as well as different weight management strategies if that is playing a picture or a role in the metabolic picture for these patients. Of note, with the criteria used to define hypertension, in the clinical trials, they did define it as 2 different occasions with a blood pressure of greater than 140 over 90. All right, next is acne. And the prevalence here is really just what we're seeing on the listserv. We did not see that, at least not documented in the clinical trials. And so this could be defined as both an increase in cystic acne or new or onset of worsening chronic acne. And of note, it is not gender specific or hormone related that we've been able to determine. And really the over-the-counter topicals remain the best first-line treatment, but certainly isotretinoin and a dermatology consult may be appropriate. Once again, this is going to be discussed a little bit more in terms of drug interactions, as well as our disease interactions with different organ systems and clearance patterns. Here at our center, we do work closely with dermatology to not make that a hard stop, but it is important to know that the increased monitoring as well as drug interactions with different, the fat-soluble vitamins does occur with isotretinoin, and we need to make sure that patients are aware of the severity of that and that it is being followed by dermatology. All right, so next I'll talk a little bit more about psychological and mood changes. So this can manifest as anxiety, depression, mood swings, fatigue, and difficulty sleeping, as well as changes in focus. This is also a really tricky management, and we've definitely seen a lot of resources come out from the foundation in terms of how to bring this up with patient as well as how to manage. But I've included a couple things here, including therapy interruption, depending on the severity of those mental health changes. Therapy interruption always needs to be on the table if things are severe. If you don't want to jump right to that, certainly temporary dose reduction and titration is appropriate. And then counseling with both a psychologist or a psychiatrist can be helpful if medications are needed, as I've alluded to in that 4th bullet. And lastly, I felt silly adding this as an adverse effect, but I think it's worth mentioning, this was a primary kind of conclusion that we saw from the initiation of triple therapy. Is one of the huge benefits is we get weight gain in these patients who oftentimes we've been looking for a really long time. So with the clinical trials for triple therapy, we saw an increase of 1 kilogram per meter squared, or 1 BMI point. And a lot of this is thought to be due to a change in energy usage. So how much energy and calories the lungs are using to burn or burning with the work of breathing. At the same time, our patients are continuing that high fat and high calorie diet that they've been, doing their whole life. So this becomes a balancing act, and I think one that will continue to evolve over the coming years with our CF management. And so really, I think at this point, the most beneficial things that we can do are encourage healthy fats for co-administration with triple therapy. Sometimes patients get really caught up on that, having a really high fat meal. And so, pairing that with their breakfast and dinner, and then choosing healthy options and looking at those fat contents can be helpful. One big thing that I've found in our center, both pediatric and adult, is discussing the type of milk a patient is drinking. Oftentimes I've had patients, drinking their whole milk or half and half, and continuing to do that. And we're talking about weight, and that's something we can forget about really easily. So considering moving down to 2% or even 1% or skim, what the rest of their family is drinking. And then encouraging daily exercise as well as other healthy lifestyle habits. With this weight gain occurring, CF is becoming much more manageable. And so we need to make sure that patients have those healthy lifestyle habits. So in conclusion, I think it's important to assess all the adverse effects, including temporal relationships and other changes. So when did the side effects happen? When did triple therapy start? And kind of build up that timeline for occurrence. And don't always assume it's medication related. We've alluded to many causes for some of these adverse effects. And so we want to work with patients to manage them, but also to maximize the number of patients that are able to stay on triple therapy, because we know that that is going to be extremely beneficial for their health. And with that, I will close, and I look forward to talking with you more during the FAQ section at the end. Thank you.
Hello, my name is Michelle Simonson, and I'm a pharmacist at the University of Kansas Adult and Pediatric Cystic Fibrosis Care Centers. Today, I'll be presenting Interaction Intersection when highly effective CFTR modulators meet other necessary therapies. The following relationship exists related to this presentation. I participated in a Vertex Pharmaceutical Advisory Board in spring of 2019. Triple therapy has multiple metabolism and transport effects. Although I could easily spend over an hour diving into all of the dosing challenges that I and other CF pharmacists have come across in the past 2 years, I will focus instead on the 2 highlighted areas because there aren't clear recommendations for how to handle them. During this presentation, I will evaluate the interaction between Elexacaftor and bilirubin and see how that interaction plays out in the setting of Gilbert syndrome. Then I will go on to discuss the management of LFT elevations with triple therapy, with a focus on handling scenarios beyond recommendations in the package insert and in the setting of concurrent hepatotoxic therapies. I will now focus on the impact Elexacaftor's interaction with bilirubin binding at the OATP 1B1 and B3 transporters has in clinical practice. Unlike the tezacaftor ivacaftor approval trials, in trial 1 for Elexacaftor, isolated hyperbilirubinemia was evaluated and reported. Blood bilirubin increases were seen in 5% of patients treated with Elexacaftor and in 1% of patients treated with placebo. Indirect and direct bilirubin elevations greater than 1.5 times upper limit of normal occurred in 11% and 3% of Elexacaftor treated patients, respectively. No Elexacaftor treated patients developed maximum direct bilirubin elevations greater than 2 times upper limit of normal. We have encountered several instances of isolated hyperbilirubinemia in our practice, and I wanted to discuss one with you today. Patient NN is a 36-year-old female who is homozygous for F508 delta with baseline lung function in the mid-80s on Taz-Iva prior to the approval of Elexacaftor. She had mild bilirubin elevations in the past, but never exceeding 1.4. Here is a chart showing her total bilirubin levels prior to and during her first 6 months on and off of treatment with triple therapy. Her T-bili prior to initiation was 1.2. She started on triple therapy and 3 weeks later emailed to report a slight yellow color in her eyes. Labs were ordered and obtained the same day, and her T-bili was 2.1. Liver enzymes drawn at the same time were minimally above normal range, which was elevated for her, and triple therapy was held and labs were repeated the next day. Recheck the next day revealed a T-bili of 1.8 and liver enzymes now in the normal range. She was advised to continue to hold triple therapy, and her T-bili within 4 days of stopping was down to 0.7. She was referred to hepatology, and her bilirubin continued to fluctuate that spring well off of it. Preceding her August clinic visit with hepatology, genetic testing for Gilbert syndrome was done, and it confirmed a diagnosis of Gilbert's. Gilbert syndrome was first described by Augustin Gilbert and his colleagues in 1901. It was characterized by mild and intermittent elevation of the unconjugated bilirubin levels in the absence of hemolysis or hepatocellular disease. It's an inherited condition, being either autosomal recessive or dominant, depending on the other causative mutation, and it affects 2 to 10% of the Western world. Elevations in bilirubin are seen when the body is under stress or during hormonal fluctuations. Examples of those include physical exertion, fasting, sleep deprivation, alcohol consumption, dehydration, surgery, and menses. Gilbert syndrome is caused by a defect in the hepatic conjugating enzyme uridine diphosphate glucuronosyltransferase, which is encoded by the UGT1A1 gene. This defect results in reduced bilirubin conjugation. In general, it's a diagnosis of exclusion. However, genetic testing can be performed and is appropriate if there's either diagnostic uncertainty or the patient or care team is particularly anxious. Often, symptomatic elevations are found during routine lab monitoring. Some patients may notice jaundice with T-bili levels greater than 2.3, and sclerolicterus can be seen with even slightly lower levels, as seen in our patient. Episodes generally resolve on their own. Starting triple therapy may identify people who have subclinical Gilbert's by further inhibiting the pathway for bilirubin clearance. It's believed that Elexacaftor binds to and competitively inhibits the OATP1B1 and B3 proteins, and those are partly responsible for bilirubin uptake into the liver. Gilbert syndrome reduces the glucuronidation needed to conjugate bilirubin for excretion. In combination, the Elexacaftor and Gilbert syndrome increase unconjugated or indirect bilirubin in circulation, leading to symptomatic or lab presentation of hyperbilirubinemia. Going back to our patient NN, her triple therapy was resumed after formal evaluation by hepatology in August of 2020. Her last 2 bilirubin levels have been elevated at 2.3, but interestingly enough, the patient reports that she has not been symptomatic. She started back on oral contraceptives to help manage acne and feels it has leveled out her hormones, which in turn has minimized her bilirubin fluctuations and symptoms. Takeaway points from NN's case, as well as the other 5 cases which we encountered at our center with triple therapy initiation, include Elexacaftor in the setting of Gilbert syndrome may have additive effects on elevations in bilirubin. Refer to hepatology if additional concerning factors are present or if you are desiring definitive diagnosis with genetic testing. It's helpful to the patient to counsel on exacerbating factors for GS so that they can have a better understanding of the disease. And lastly, in GS, total bilirubin levels will rarely exceed 5, and neurotoxicity does not start occurring until much higher than that. So although patients may have symptomatic bilirubin elevations with the presence of jaundice, this symptom remains benign. Now I will focus on the management of LFT elevations with Elexacaftor in the setting of concurrent hepatotoxic medications or alone. I wanted to briefly discuss the difference between liver injury and liver function. Although liver injury is indicated by elevations in serum aminotransferase levels, injury itself does not necessarily lead to clinically significant liver disease. The liver has a great healing capacity and adaptive tolerance. Pre-existing liver disease and coexisting illnesses may actually have a greater effect on the ability of the patient to recover from liver injury than it does on the likelihood that it will develop in the first place. I think that this concept is important in the setting of CF, where CF liver disease can be at play. In trial 1 for Elexacaftor, the incidence of adverse reactions of transaminase elevations, AST and or ALT elevations was 11% in the Elexacaftor treated patients and 4% in placebo treated patients. In the recent approval of Elexacaftor for 6 to 11-year-olds, ALT elevations seen were similar to the adult studies. This adverse effect is why prescribing information recommends assessment of LFTs every 3 months for the first year of treatment, or more frequently if the patient has a history of LFT elevations or hepatobiliary disease. The full prescribing information then goes on to further recommend holding triple therapy with AST or ALT greater than 5 times upper limit of normal, or if LFTs are greater than 3 times upper limit, plus the bilirubin is elevated at greater than 2 times upper limit. And you're only supposed to resume once the levels have normalized and the risk versus benefit has been assessed. What I want to do here is discuss this gray zone. Like, how do we handle scenarios where LFTs intermittently shoot into the greater than 3 or greater than 5 zone, or go from normal to elevated and back? To discuss this gray zone, I'd like to introduce another patient case. Patient CJ is a 16-year-old female who is enrolled in the VX445 clinical trial at our center. I was not involved in the study, but based on her lung functions measured outside of study records, it seemed very apparent to both her, her family, and her CF care team that she had been receiving placebo up until rollover to open label in January of 2019. That's because in a matter of weeks, her lung function went from an average of 70% to the mid-90s. Her LFTs prior to January had been completely normal, apart from mild elevations in alk phos. During her time in the clinical trial, Elexacaftor was held and restarted a total of 3 times for elevations in AST and or ALT of varying degrees. She was seen by hepatology during her 3rd treatment interruption, and ultimately she and her family decided to unenroll from the clinical trial in hopes of continuing on therapy with more minimized interruptions. This graph depicts the drops in CJ's lung function during interruptions in therapy. Those dips were often associated with a return of symptoms plus or minus exacerbation. After her 2nd visit with hepatology, the team decided to reduce her triple therapy dose in hopes of continuing treatment with minimal to no interruptions. She was empirically started on Child-Pugh's Class B dosing of 2 orange tablets daily every other day, alternating with 1 orange tablet daily every other day. Much to the team's relief, her subsequent spirometries exceeded her previous high, and her LFTs remained stable at less than 1.5 times upper limit of normal. We continue to monitor her LFTs at least every 3 months, and she continues to follow with hepatology. As I mentioned before, each discontinuation in modulator treatment resulted in return in pulmonary symptoms, sometimes with pulmonary exacerbation requiring oral antibiotics. This left the team with a challenge. How do we keep her on therapy but limit the interruptions in treatment with the resulting recurrence of symptoms and the emotional toll the treatment roller coaster took on her and her family? We very much wanted her to be on triple therapy with all of its benefits, but also wanted to protect her liver. These were the factors that led us to a dose reduction, which she has successfully continued on for 9 months now without interruption. The ongoing challenges of managing LFT elevations led us to develop an algorithm addressing that gray zone in our adult CF clinic. This chart provides guidance to our nurses and providers on when to repeat labs and how often. The second portion of our algorithm addresses considerations for ongoing LFT elevations. On third repeat, if enzymes are not trending down, it becomes time to consider things such as removal of other potential hepatotoxic medications, a hepatology consult, dose modification. If the LFTs are elevated but stable, it may be most appropriate to continue every 3-month monitoring of LFTs beyond the 1-year mark. And past LFT elevations or known CF liver disease likely warrants more frequent monitoring past the 1-year mark of triple treatments, such as every 6 months. Of course, each patient scenario is unique and may require a more custom monitoring plan. This chart, adapted from a review article by Navarro et al., lists medications well known to cause hepatotoxicity. As mentioned in our algorithm, evaluation of other medications contributing to LFT elevations is essential. This list is a good starting reference, and I highlighted medications commonly seen in our patient population. And though it is a good reference, the medication list is not comprehensive. For example, azithromycin and levofloxacin, 2 agents that are commonly used in our patient population, although not on this list, have dozens of case reports of hepatotoxicity each, with the mechanism being less understood. Isotretinoin, which has been used in our patients battling challenging and possibly modulator-induced acne, is also well known to cause transaminitis. The risk benefit of triple therapy needs to be considered in conjunction with the risk benefit of the patient's other medication therapies. Participating in the CF Foundation's pharmacist and technician listserv has been really helpful in allowing me to see how other centers handle these challenging situations for which there is no guidance and little to no literature. Multiple centers have trialed dose reductions and or dose titrations, and our center has experimented with both as well. As discussed with our case patient CJ, the most common dose reduction we do is the Child-Pugh's Class B recommendation. Both dose titration and dose reduction can help patients achieve maximum benefit from triple therapy while minimizing stress on the liver. Being aware of hepatotoxic medications and those known to cause LFT elevations can help when managing or attempting to prevent LFT elevations. Both dose reduction and dose titration on triple therapy can be appropriate strategies if the removal of the offending agent is not possible. One example of this shared on the listserv was the initiation of isotretinoin for patients managing challenging acne. Depending on the patient, reducing the dose of triple therapy and titrating up may be appropriate if concern is present. For others, continuing full dose and monitoring labs more frequently may be sufficient. In conclusion, isolated hyperbilirubinemia with Elexacaftor is caused by Elexacaftor's binding to OATP 1B1 and B3 and can be worsened by Gilbert syndrome. Strategies for management of LFT elevations with Elexacaftor include dose titration, dose reduction, and minimization of concomitant hepatotoxic medications. Early referral to hepatology can delineate if lab abnormalities are secondary to medication, CF liver disease, or an alternate cause, and assist in care plan and the need for dose adjustments and the monitoring. It's important to note that no cases of significant liver toxicity have been reported with triple therapy to date, but diligence in patient monitoring is essential to assuring the long-term well-being of our patients on treatment. And with that, I will Look forward to taking questions during our live Q&A session. And a special thank you to my patients who I've had the opportunity of helping to initiate and continue on triple therapy. Thank you.
Welcome, and thank you all for joining me today to talk about treating pregnant and lactating women with highly effective CFTR modulators. My name is Sabrina Sherwood, and I'm a clinical pharmacist at St. Luke's Cystic Fibrosis Center located in Boise, Idaho. I have no relationships to disclose related to this presentation. So in a short amount of time today, we're going to examine why this topic is meaningful. We will also examine the most recent publications in relation to safety and monitoring of modulator use in women with CF who are pregnant or lactating. And here's a roadmap of where we're going to go today. So first, we'll talk about why this topic is important and why it's one of the most trending topics across the US in terms of the listserv searches. We'll also talk about the evidence for pregnancy, lactation. We'll talk a little bit about monitoring and then some future directions. So firstly, I think one of the reasons why this is such a hot topic is because we have more patients eligible for modulator therapy now than we ever have. About 90% of the adult CF population is eligible for a modulator in the US. Second, the number of pregnancies in women with CF is increasing very quickly. In 2019, a total of 310 pregnancies were reported to the registry, which was up from 137 in 1999. As you know, though, Tricafta wasn't approved till October 2019, meaning that the number in 2020 and 2021 is anticipated to be much higher. Baby boom? Well, if you're a person with CF, you've probably heard of the Tricapta baby boom affecting someone you know or maybe even yourself. And if you're working with CF patients, you might be wondering if the increase in pregnancies that you're seeing, is it all related to this or is it just coincidence? Well, we call it a Tricapta baby boom, but could it just be a highly effective modulator boom? In 2018, a survey was done pre-Tricapta that found at least 80% of women expressed a desire to become pregnant in the future. So could this be related to modulators, not just Tricapta, that are making patients feel healthier overall? Maybe. But we do know it's a subject worth talking about because patients are wanting to become pregnant. I want to give you all a real-life example of a patient who called our CF clinic. She's a 31-year-old female who started Tricafta in the last 4 months. She was taking a progesterone-only contraceptive and recently had unprotected sex. She called the clinic in a panic saying, "Sabrina, I'm nervous. I just checked my calendar and I'm 7 days overdue for my period. Could I be pregnant? What do I need to do and what do I need to stop taking?" The patient had also expressed that being pregnant is not something she really had wanted for herself at the time, so she was clearly nervous and upset. Please take a minute to think about this case and write down what questions you have for the patient and what a good next step might be, and we'll come back to it. So Kazmersky and colleagues surveyed young women with cystic fibrosis regarding sexual and reproductive health behaviors. They found that a smaller amount of women with CF had used a form of contraception in the past than the general population. I wanted to take a minute to highlight the need for contraceptive counseling for our CF patients. Many patients who previously felt that they may be unable to have children are now on highly effective modulators that may be increasing the likelihood of pregnancy. Unplanned pregnancies are especially difficult for our patients with cystic fibrosis, both mentally and physically. It should be our mission to ensure each patient has the chance to explore contraceptive options to decide the right option for herself and her family. So do modulators increase fertility? Well, Jane and colleagues hypothesized a way that this could be happening in their 2021 review titled Pregnancy and CF Review of the Literature and Expert Recommendations. It's believable to think that through improved nutrition and improved lung function, this could help mother become stronger, which could in turn have some indirect benefits to the baby. There's also this idea that modulators such as Tricapta decrease the viscosity of the cervical mucus and increase the pH of the cervical mucus, which could allow for easier conception. So back to our patient case. What kind of questions do you have for the patients? So the first one I asked her was, are your cycles usually regular, or have you had a change in how your cycles have been since starting Tricafta? The patient tells me her cycles have changed since starting Tricapta, but none have been this late, so she's still pretty worried. The second question I ask is, how are you taking your progesterone? So she tells me at this point she's taking it every single day, just as she's supposed to, and she skips her placebo week at the end of the last 7 days of each month. So quickly, we identified that she was on a contraceptive pill that did not have a placebo week, and she should have been taking it every single day. So we educated her on this change and also on the nuance of taking progesterone pills at the same time each day, which is a nuance that often gets overlooked. So we encourage the patient to take the medication appropriately. But in this time period, what we really encouraged her to do was to go and get a pregnancy test. So on her way out of the clinic, she actually started, on her way to get the pregnancy test, she actually started her period. And so this was a close to home reminder that it is important to talk about contraceptives often. And we're learning that this has become especially important in our patients on modulators. One key takeaway from this presentation is that anyone on the care team can ask a patient what their plan for contraception is. So please be the one to do it. Even if you don't know the clinical answer to a question, you can always be the one to bring up the subject, because a lot of times patients just need a little bit more education about what contraceptive options there are. Our next case is a 26-year-old female who presents for a normal CF follow-up who's interested in starting a family. She's wondering if Tricapta is safe during pregnancy and is looking to you for some insight. So think about her throughout the rest of this presentation. Let's talk about modulators during pregnancy and circle back to this patient. So this is what I like to call a mom and baby-centered care team. After counseling many mothers with CF and asking them where their care can be improved, time and time again, they come back to communication among their care team. I've heard patients express frustration over a maternal fetal medicine provider asking them to stop a medication and their CF team stating they should continue this medication. Once a baby's born, a pediatrician is also in the picture. And this pediatrician may not have extensive experience caring for infants who are exposed to a modulator and may be unsure what to do in terms of monitoring. We can improve the patient care experience by improving communication among all of these parties, and I have a few suggestions on how we can do this later in the presentation. So we know that the question of continuing a modulator during pregnancy is not a simple yes or no answer. Here are 4 major topics I like to discuss in depth with patients when it is time to make this decision. First, on the left, this is the pros for continuing a modulator. Include potential benefit of improved health to mom, which could improve the health of the baby. This goes hand in hand with the other pro of continuing, which is that discontinuation of this medication can be life-threatening, as we'll discuss. On the right-hand side, the cons or reasons to consider stopping a modulator. We cannot deny that there is a paucity of literature related to the safety of the infant exposed to a modulator in utero. We do not know the long-term effects that giving a modulator could have on an infant months or years after exposure. This information on this model was adapted from a 2021 article by Jane and colleagues. Please remember that these components listed here in this table were only studied in rat and rabbit models as individual components and not the compound that they are administered as. So lumacaftor, not Orkambi, tezacaftor, not Symdeco, Elexacaftor, not Tricafta. It is known that these components do cross the placenta and therefore exposure is inevitable. I gave this data chart a pro and con symbol because I think the findings of this speak to each side of the decision. So on the pro side, it does appear that the individual components do not negatively impact fetal survival, even when the mother was given toxic doses, which all of these studies were using. Now on the con side, they did see some congenital abnormalities in the tezacaftor group, but not in other groups. And again, these were with doses that would not be used in a human. They did also find decreased weight of the fetus in all groups except the lumacaftor one. But again, this was at toxic doses. On the pro side of the decision, a few real-world evidence reviews are starting to be published that describe the outcomes in infants born to mothers on a modulator. In a 2021 survey by Dr. Taylor Kauser and colleagues, they followed 45 pregnancies to delivery, all of which were exposed to Tricapta. No infant complications were deemed relatable to the maternal Tricapta use. However, 5 complications did occur, and they were deemed to be unknown or possibly related to Tricapta. Of the 3 infants that they noticed with mild congenital malformations, 2 of these were born to mothers with poorly controlled diabetes, which we know is a risk factor for this complication on its own. Nash and colleagues published a case series in 2020 describing 44 pregnancies in patients exposed to modulator therapy at some point in the pregnancy, and none of these patients were exposed to Tricapta. Although no infant complications were found, they did, however, find 9 complications in the mom suspected to be related to discontinuation of the modulator. So some moms had discontinued the modulator throughout pregnancy, had some bad complications such as FEV1 decline and pulmonary exacerbation, and as a result, some of them actually restarted the modulator. Many of you will remember the publication from 2018 by Trimble and colleagues that I actually refer to pretty often when I'm counseling patients on the risks and benefits of starting a modulator for the first time. Recall that this highly cited publication composed of 3 case reports detailing the specific clinical decline experienced when patients suddenly discontinue modulator therapy. Although we do not have time to review this in detail today, please take a look at the graphs in this publication to see clearly that within about 3 to 4 days of modulator discontinuation, patient lung function and health takes a pretty sharp deterioration. 1 patient in the study died in the case report. Clinically, many of us have even seen this firsthand. And I do believe the decision to continue or stop a modulator in a patient must also consider the findings of this phenomenon, which is commonly referred to as modulator withdrawal. So another pro to continuing. So back to this case. If we were able to engage in person, I'd ask you all to take a minute to practice with a partner how you would navigate this discussion with the patient. Can you remember the 4 talking points that I bring up with each patient? And can you paraphrase some of the most current literature that we have covered today? Well, we can't forget about what happens after pregnancy. So now let's move on to lactation. So this is another true case. You receive a call from a pediatrician about a 4-month-old breastfed male born to a woman with CF who's currently taking Tricapta. You can see his LFT results below. This is the baby's LFT results. And you can see they've risen a little bit. The pediatrician wants to know if this increase in LFTs could be related to Tricapta. So like we did for pregnancy, let's start with animal model findings for use of the individual components in lactation. We know that these compounds are excreted in breast milk. We also found in this study that the cataracts were observed in juvenile animals when exposed to ivacaftor, regardless if it was at a toxic dose or not. Because of this, there is potential of cataract formation noted with each compound that also includes ivacaftor, which is going to include all of our commercially available modulators. We will come back to what we can do about this at a later time in the presentation. The literature related to modulator use in lactation is incredibly sparse and maybe even more so than with pregnancy. We do know that the individual components are excreted in breast milk, but the question is, does this affect outcomes? The same survey and case series that we looked at for pregnancy by Nash and Taylor-Kauser also evaluated a subset of patients who continued modulator use during lactation. They found no adverse effects in the infant. There was a case report by Maines and colleagues that also found no adverse effects. Trimble and colleagues had a case report of 1 infant exposed to Orkambi during lactation who had elevated liver enzymes in the first month of life. The team then worked with the patient to suggest switching the infant to a 75% formula, 25% breast milk split, and found resolution of elevated enzymes in about 1 week. Overall, my summary of the current literature, although it's really limited, is that modulators do appear to be safe in lactation, but we will discuss monitoring, which I do think is really important to consider if your patient wants to breastfeed an infant while on a modulator. So why would we see a potential elevation in liver enzymes in an infant exposed to a modulator anyways? Well, this may be part of the answer, so please bear with me as we get a little pharmacist nerdy for a minute. We know that infants are born with an immature CYP3A4 system. This is the major enzyme responsible for metabolism of our highly effective modulator components. We also know it can take up to about 2 years for infants to develop a fully functional CYP3A4 system. So what does that mean for the patient? Well, if a baby is given a medication that requires CYP3A4 to metabolize it, this could then increase levels of this medication in the blood. So the modulator levels in the blood could be increased for these patients exposed if their CYP3A4 system is not fully functional and therefore not able to metabolize the medication. This could, in effect, increase risk of adverse effects potentially. So that increased side effect of liver enzymes could become a possibility. So because of this potential issue and the risk of cataracts that were observed in animal models, it's important to weigh the pros and cons of safety monitoring for infants born to women on modulators. Across the US, my very informal search of various centers and what they're reporting as standard monitoring varies very widely. Some are not recommending anything or deferring to pediatricians. Some are recommending only cataract evaluation, and some are recommending both liver function monitoring and cataract monitoring in these infants exposed. So things I consider about monitoring is the duration of breastfeeding and if the mom plans to exclusively feed with breast milk or if she's planning to switch over to formula quickly. I also consider who is my pediatrician that I'm going to be working with and how do I communicate with the pediatrician to really help improve communication. So one thing that we've started to do is create a center-specific handout that has contact information. So like, for example, it would have my contact information for my desk phone so that the pediatrician could call me with questions. It would also have some potential risks to the infant in terms of what they could expect to find with modulator exposure, and then our team recommendations. And this could include some of the literature from today. So again, this kind of just goes back to that mother-baby care team model I discussed earlier. And it's just one easy way that we can improve communication and decrease frustration for our patients. So feel free to use information from this presentation today to create this specific handout. Reach out to me with questions if you do have them. Here's an algorithm I made utilizing the sparse literature that we discussed today, as well as taking kind of an average recommendation from what it appears other centers are doing across the US. So this is just a way that you could recommend getting liver function tests done for infants, and then things that you can do to improve outcomes. So splitting breast milk and formula is a very common way to do this, and then following up with liver function in about 2 weeks after. Just remember that this can be an emotional decision for the mother, so really work with her and her partner to determine if splitting breast milk and formula is something that she's willing to do. So going back to our case, the liver enzymes are trending up. The patient has an infant who is exclusively breastfed. What are you going to do? So the pediatrician wants to know if this could be due to Tricafta. So my answer would be, yes, it could potentially be due to Tricafta. I then explained to him some of the literature that we reviewed today, as well as maybe some of the cytochrome P450 systems that could be in place causing that. I'd also work with him and with the patient, him or her and the patient, to see if maybe switching up the formula a little bit could help. If they're exclusively breastfed, would they be open to splitting breast milk with formula and rechecking LFTs in 2 weeks? And this was a real case. We did split the formula. We did 25% breast milk, 75% formula, and the LFTs resolved within 2 weeks. So future directions, this is what's so exciting. So there are a few upcoming studies looking at reproductive health, including cervix mucus quality, but none are really as encompassing as this Mayflower study. Doctors Jane and Taylor Kauser, which are the authors of many other related studies here, are conducting a prospective 40-center study that's looking at the impact of pregnancy on maternal health, such as FEV1 and exacerbation rate in infant health as well. I believe these findings are going to shed more light on this topic for us and provide us more tools to have these important discussions with. So in summary, we're seeing more pregnancies and more patients that are on modulators. So we need to be confident in these discussions. We must work with the patient to come to a decision that appropriately weighs the risks and benefits of this huge choice, knowing that the data does not show that there's a right or wrong answer. We need more prospective studies, and we're really excited for the Mayflower study to have results. We also need to remember that the mom and baby care team model is important with all decisions that we choose regarding pregnancy and lactation. One step you could take today is to create an educational handout for mothers to take to their pediatricians that address potential safety monitoring and provides contact information for additional questions. Please reach out to me with any additional questions or concerns, and thank you so much.
Hi, everyone. My name is Jillian Mozak. I'm going to be presenting today on life with highly effective CFTR modulators from my own personal perspective. I live in Evansville, Indiana with my husband and our 2 kids, and I'm also a social worker. The only disclosure I have to make today is that I'm also an employee of the Cystic Fibrosis Foundation, but I'm speaking today as a person living with CF. So my story goes back to 1991 when I was born, and I was diagnosed with CF when I was 10 months old. I was in the hospital a lot those early months, and then again, beginning around age 8, I had more lung infections and required IV antibiotics. By high school, I was in the hospital 2 or 3 times per year, and I sort of unfairly cornered my doctor at the time and asked him how long he thought until I needed a lung transplant. I was having feelings of hopelessness and feeling so different from my peers who were imagining their futures, and wondered what my life might be like going forward. And so he estimated 10 to 15 years, but what I didn't know is right around the corner, there were modulators coming down the pipeline that would really change the course of my life. Among many things, I had hoped to be a mom in the future, but I never counted on that being my reality. My first CF team in Toledo, Ohio, knew of this hope, and when my husband and I got married in 2014, that same doctor who estimated I would have a lung transplant in maybe 10 to 15 years gave me the okay to pursue one pregnancy. He said, one and done. So as you can see, I kind of took that advice and then had one more. But he thought my lung function and my overall health was stable enough. And when we were ready, at this point, I had been in the study for ivacaftor. My senior year of high school, I started that. And while it didn't work for me, I had this new hope instilled in me that something was changing in the CF landscape. And it felt exciting to be a part of that. So shortly after, I began the study for lumacaftor and ivacaftor, and things really started changing for me. My health became more stable. I had less hospitalizations, even though I didn't have a big change in lung function or mucus production. My health stabilized and I recovered more fully when I was sick. So in August of 2015, kind of right after Orkambi was approved by the FDA, I found out that we were pregnant. We were surprised, and honestly, we were so unsure about what life with CF and a pregnancy would look like. We were pretty hopelessly naive about the whole thing, based on such limited conversations with my new CF team at the time. So we were excited, but we were nervous. And at my first appointment with my team, we realized they had never seen the patient through a pregnancy before. And so this was all new territory. There were lots of questions we really didn't have a lot of answers to, including data around safety in pregnancy for these modulators. And so out of an abundance of caution, we stopped Orkambi. I had to stop out of the study as well because you can't get pregnant in the study. And I did have a dip in lung function at the beginning. I went on on oral antibiotics one time in my pregnancy, but otherwise remained like fairly stable out of the hospital. Putting on weight was a little bit more difficult in this pregnancy, but I also saw a high risk OB at the same hospital as my CF team, and they had never seen a pregnancy in a person with CF before either. So quite frankly, during this pregnancy, I felt like a bit of a circus act where everyone was watching me. Nobody had a lot of answers, a lot of uncertainty, and we didn't feel confident. I also only knew of one other person ever personally who had a pregnancy with CF. And she was doing well, but I didn't know her very well. And I also didn't know the broader community. This was like 6 years ago when the internet was even different then. And so I felt very isolated during this time, like I was the only one. So we had a lot of questions, but we continued through this pregnancy, and I did feel more junky in my lungs, not having Leqembi, and ended up, going through this pregnancy pretty healthy. 10 days early, I was induced and had a non-eventful labor and delivery. Simon was born 6 pounds, and he was beautiful. And it was such a joy to share this experience with this is my original CF team you see in this picture. My social worker, Kim, who knew me when I was a baby, and my pulmonologist, Dr. Bruce Barnett. And they were part of what got me to that point where I was healthy enough to take modulators and to have a baby. So after he was born, again, everything went pretty smoothly. We were surprised. And I didn't feel strongly about breastfeeding during that time, during the time of pregnancy. But when Simon was born, I did. I felt very strongly that I wanted to do this. I wanted to provide for him in that way, seeing my body as capable after, years of living with CF and viewing my body as something that wasn't always working well. It was important for me to explore this opportunity because I knew it was, going to be beneficial for him as well. So at that time, again, not a lot of data. So we held off on restarting Leqembi while I was breastfeeding. And in February of 2017, I was hospitalized and on IVs for the first time in 6 years, which was pretty exciting. That I had gone that long, but it was very, very hard to be away from Simon, who was 9 months old, and hard on my whole family. So after this kind of dip in lung function and struggle, we decided that I should restart Leqembi. And I haven't had to navigate these big decisions with my CF team with not a lot of data and with Simon's pediatricians because I still did want to try breastfeeding. And we decided to follow up on his liver function as well to be sure that there was no damage being done. This was a time, kind of a turning point where I knew I had to put my health first. I was always trying to balance, CF and my appointments, my treatments, 3 a day at the time. All of that was just part of my mothering as well. That was Simon and I were figuring this out as we went. I'm going to move my picture a little bit so you can see. This is my nurse, Kay Burris, at the time, who instilled in me such a love for being a mother, but also reminded me that I was doing a great job as a mom. And it was okay to take time to take care of myself and be the best mom I could be. She was so encouraging. We talked about CF stuff as much as we talked about parenting stuff. And that was something really impactful for me, that she saw me as a whole person, as a mom, and not just a patient with CF. And Kay died suddenly in June of 2019, but she left a huge impact on me and my motherhood and taking care of myself with CF. And you'll see her name pop up again later in my presentation. But flash forward to summer of 2019, life kind of calmed down a little bit. Simon was 3. We got a dog, Teddy, who you see, the big ball of fur. And I finished grad school. We were considering growing our family some more. And at that time, it seemed like Tricafta was kind of on the horizon. There was a lot of talk of the triple combo. And I had a lot of hope that it would be really powerful. And I didn't want to see the huge gains in Tricafta only to have to stop because of a pregnancy, because again, we wouldn't have any data with it being so new. So we decided that we were gonna try for another baby, and that was not a simple decision. It was made very thoughtfully and as carefully as we could. You can't predict anyone, CF or not, what your life is going to be like, but it was kind of a leap of faith and something that we had on our hearts, that we really wanted another child, and we thought that it was reasonable to think that my health was stable and we could do that. So I actually switched to a new OB-GYN who, again, from day one was quite confident in me and asked me right away if I was wanting another baby, to which I was very surprised that she wasn't just concerned about CF. And I switched to a new CF center as well that had a lot more experience with pregnancies. And again, first appointment, that was part of our conversation. And they were more confident than me that I could have another baby if that's what I wanted. They saw me as a whole person first, with desires and dreams, and believed that I could even have those. And that was sort of new for me. I was in my mid-20s and never knew if I would even live to be that age. And so I needed my team to believe in me, my OB included. And that confidence and that hope that they carried with them made such a huge impact on me. So we're kind of waiting for Tricafta. We wanted to see if we could have this baby before I started, and my health was pretty stable. Our lives were, again, kind of calming down, so we went for it. And Tricafta ended up being approved a little early in October of 2019, and we still weren't pregnant. So I got Tricafta. It waited in my cupboard for a few months, and we kind of kept considering, should we start, should we not? And I got a virus in January of 2020, and had a little bit of a dip in my weight and my lung function again. And we decided, let's start. My team was fully supportive of me being on Tricafta and pursuing a pregnancy. And so after that happened, we decided to start. And within days, my cough lessened. Here's me starting Tricafta with my super fatty meal in front of me. It was like overnight. Things were so different. I put on weight pretty quickly, and actually within 3 weeks, we found out that we were pregnant. So things did change awfully quickly. So thanks to the research that continues to be done on pregnancy and lactation with modulators, we decided we were going to continue Tricafta, and my doctor supported me breastfeeding as well. We'll say navigating a high-risk pregnancy in a pandemic with a toddler and both working from home was quite the journey, but we did it, and I felt healthy and strong most of my pregnancy. I'm going to move this picture again so you can see my nurse Barb, who so valiantly helped me through my labor. And again, I had another unmedicated, non-eventful labor. Everything went pretty well. Baby's blood sugars were fine despite my CFRD, which was well controlled through pregnancy. I was able to go home within 24 hours. I felt the most normal I'd ever felt in the hospital before, because I wasn't this circus act that I felt like I was the first pregnancy. COVID kind of helped with that too. It helped us get home quickly and keep the experience a little bit more private, I think. And I worked out 3 days a week during my pregnancy, at least, through Beam, which is a platform for people with CF, and maintained some friendships there. A lot of encouragement from other people with CF also exercising with me. And that was a new experience. Again, Tricafta was giving me this new ability to exercise, and not just exercise, but in pregnancy, I was literally running down the block with my 5-year-old, my 4-year-old at the time, who the night before I went into labor, I felt amazing. Truly, it's hard to put words to what a difference it felt like, and sort of realizing then on Tricafta and even pregnant how sick I was before and how hard it was just to breathe and what it's like to have mucus in your lungs all the time. My breath feels clear and deeper, and I felt so capable. So Eloise K. Mozak was born on October 17th. She was 6 pounds and 3 ounces. And it was, we took a risk by deciding to do this. And I think we made the best decisions we could with what we had. So we did decide afterwards to pursue liver function testing for Eloise as well. Just like we had with Simon, his were always normal, but hers came up just a little bit elevated after she was born, or after she was 5 months old when we first tested. So everything was fine when she was born. I was on Tricafta during pregnancy and then breastfeeding as well. So we knew that my CF team actually encouraged the pediatrician to do the levels, but I was sort of the middle woman for that and helped coordinate that. Now, I'll never forget when the pediatrician wrote the labs. He didn't know how to code the order, and he wrote exposure to toxin in utero on the lab work. And you can imagine, as a mom of a fresh little baby, that looks pretty terrible and felt pretty crummy to see that. Even though he thought we were being abundantly cautious and she was fine, that's just the wording he decided to use for this testing. And that kind of stung to consider this might be harmful for her. And it was hard not to have clear answers. As I said, her levels were just a little bit elevated. Her AST and her ALT came back just over normal range. So we repeated them again in 2 weeks when they had risen just again a little bit more. And because most infants don't have AST and ALT checked regularly or randomly without any other reason to check them, we couldn't be sure that Tricafta was even the cause for this elevation. So I reached out to my CF team right away. We reached out to other clinicians on the listserv. And at this point, there were so few babies who had been born on Tricafta, and even fewer who were checking LFTs for their babies. No one else that we knew of had a case of this. So initially I was crushed. I felt kind of lost as a mom, needing this medicine to help me so much. I'd experienced these great gains, but also wanting as a parent to make the decision I thought was what I wanted to do. And that was continue nursing. But instead of making any sudden or dramatic decisions, my team helped me carefully consider what we could do and look for answers. So we decided to cut back on my Tricafta dose by eliminating the blue pill at nighttime and retest in a few weeks. And during that time, we also fed her a bottle or two of formula. And my mucus production did increase during this time. So I definitely felt a difference. And I knew that it wasn't sustainable for me to stop Tricafta once I kind of cut back on the dose. If I had to decide between the two, I was prepared to stop nursing. But her levels did slowly go back into normal range. Both the pediatrician and my CF team thought it would be okay to reintroduce the blue pill at night and continue to monitor her LFTs every few months. So she's due for them again very soon at her 1-year checkup. But she's now getting nutrition from food as well. She's bigger and getting older. So I'm much less concerned than I was back then when she was just, a tiny infant. I'm grateful for my team's compassionate response and thorough help working through this issue so that I could make the best decision possible for me and Eloise. So from my whole story, I just have a few takeaways for clinicians that I think would be, perhaps helpful for similar situations. confidently partnering with your patient. It was huge for me to have my doctor's confidence and hope, as I mentioned, to kind of go in this uncharted territory and to connect with other teams who have maybe experienced something similar. My team didn't bat an eye at me having another baby, and I was just shocked at their willingness to work with me and go into this gray area of, we don't really know, but we're going to help you figure it out. Another piece that has been so crucial is communicating. There's a lot to coordinate between the OB and the CF team, then the baby's pediatrician, the endocrinologist. It would be nice to have, a letter or maybe just a little list of things to consider for either the OB about CF, causing them not to freak out. Maybe with the first team that would have been helpful, or as well as one for the pediatrician. So I was trying to explain Tricafta, and he's feeling totally out of his league, wanting to empower each specialty with kind of information of how we can proceed together on this. I think staying flexible is another really important piece. Had virtual appointments, as it's like a lot to coordinate childcare and driving 3 hours to my CF center. Just my team understanding the additional role I have as a mom that takes up a lot of my time and bandwidth. And, we communicate often via email as well. And then I think coming up with a plan, considering the extra burdens and loads and responsibilities that you have, having CF and being postpartum, and just that motherhood has to look a little bit differently. So how can we integrate needs as a person with CF and your needs as a mom? Something that was perhaps the most invaluable for me this time around has been the village of other moms with CF whose shared experiences and wisdom have guided me through lots of days and nights. And I have a handful of CF moms that I keep in touch with. And I say CF moms, meaning moms with CF. And they're some of my dearest friends because they understand what it's like to send your kid to preschool and worry about getting the germs at home, or, making these difficult decisions that are so unique to this experience. These times have changed from when becoming a mom with CF seemed like a really far off dream. And becoming a mom has made me see my body in a new light, not one of just brokenness and having CF and doing things incorrectly, but one that has a lot of strength as well. And I'm so glad that I get to be on this journey. It's a gift that I try to remember as a gift every single day. When I think back to that 15-year-old in the hospital room expecting a lung transplant by this age, and that modulators in my CF care have given me this chance, has been incredible. So I thank you all for the opportunity to share my story with you. And I'm happy to answer any questions during the Q&A time. Thank you.
Hello, everyone. Thank you for joining us for today's presentation. We hope that you found it useful in your clinical practice. Please continue to enter questions into the chat, and we will try to answer as many as we can today. To start, Michelle, last month Vertex revised their package insert in regards to use in liver disease. Has your center decided to change any recommendations for continuing triple therapy in light of these new package insert warnings?
Thanks, Brittany. Great question. We actually came together as an adult team to kind of discuss what we wanted to do as far as handling the new information. And for the most part, we've really decided that, the benefit of Tricafta, even in our liver disease patients, or Elexacaftor in our liver disease patients, really outweighs the risks. However, it does really further emphasize the importance of very more frequent monitoring for patients with liver disease, and having a close relationship with the hepatologist that is caring for that patient, so that we can make sure that we're all on the same page. And then also important to include the patient themselves in that conversation and making sure that they're aware of the updated recommendations and having that conversation with them so that everyone's on the same page and comfortable with the plan moving forward and understanding the importance of monitoring.
Excellent. Thank you. Moving over to Sabrina. Interestingly, earlier today, we discussed as well that pregnancies have continued to increase. And I was interested in your comment about everyone playing a role in the reproductive health discussion. Could you tell us a little bit more about your approach to talking with patients regarding contraception?
Absolutely. And I'm so glad that you brought up that interesting information that dropped earlier today. I wish I had that information when I was putting together that slide, because you would have seen that huge rise in pregnancies that has happened that we all anticipated, but now we kind of get to see. When it comes to contraception, I think it's really important to look at that as an open-ended question. And as I believe it was Michelle in the chat mentioned, framing it as kind of a question for the patients as to what are you doing to prevent pregnancy is a great way to start that conversation. I think that this can go so many different directions and spark a lot of different conversations for patients regarding what their thoughts and feelings are in preventing pregnancy. Maybe they're ready to start trying for a kid and you just didn't know that up until that point. And so really being able to work with that patient and see where they're at is really important. And then kind of leading off that, it also gives you the opportunity to talk about ways that you can prevent pregnancy if they just didn't think they were able to get pregnant before. So it's a great thing to do. I think it's something that I'll start to include in my template, is just to include a little section of what is my patient doing to prevent pregnancy. That way I hit it every single time and we can talk about it. I think it's worth talking about with this baby boom that we're seeing. And open-ended questions are always the best.
Excellent. Thank you. I know that's something a lot of us can probably improve on in our practice. One of the questions that came in for me was, how do I explain to patients the rationale for flipping that AM and PM dose? And really, in terms of my counseling for patients, I do try to emphasize the difference between those morning and evening doses. If patients were on Symdeko before, they maybe notice that difference. But for patients switching from either Kalydeco or Orkambi, when those morning and evening doses were the same, it may be new information for them. And so I think the most important thing would just be to emphasize the different components. And while we may not know exactly why it makes a difference, potentially something with that Elexacaftor being given at night may cause less of the adverse effects. So just to reiterate, I think, I don't have a great answer for why it works. But I think explaining that that's the rationale is, these medicine or each of those tablets just have different components and that might have some role. All right, the next question is for Michelle. What level of bilirubin would you be comfortable with? I know you mentioned, it typically doesn't go above 5 and we don't have toxicity until 17, but is there a general range that you or your team is comfortable with?
So in any scenario where we start seeing fluctuations that are above what the patient's norm had been previously, I think we, one, start monitoring more closely or more frequently, and then two, generally involve hepatology pretty early in that conversation and get patient referred if they aren't already tied in to kind of get recommendations from them. But then, if we have a full workup from hepatology and don't really see other causes or other reasoning for that elevated bilirubin besides, the possible just the Elexacaftor interaction or the combined Elexacaftor Gilbere's. And so we will usually let it ride up to 5 or 5.5. We have in a couple of cases seen it go slightly above 5. But as long as we're following and we don't see other elevations, then we kind of are comfortable with that level, as long as, the patient is in full understanding that, any symptoms of jaundice are really benign.
Excellent. Thanks for clarifying that. Jillian, I have a question for you, and thank you. I'm sure everyone who's watching this presentation is truly inspired by you sharing your story, so thank you. One question, you talked a little bit about the resources that you found helpful, especially being a mom going back to work and having a care provider. Is there any additional information, either for your family or people who are helping with your family or children, that resources that you would find beneficial for them?
Yeah, really good question. I'm going to give a shameless plug. I actually work on the CF Peer Connect team, and I mentioned at the end, I don't think CF Peer Connect is the only way you can find that kind of support, but I mentioned at the end having kind of that village of other moms who have CF that just understand those unique challenges. Those are the first people I texted whenever I have an issue, because they know how to navigate those with that same kind of mindset as a mom with CF. So finding that support, whether it's through like a Facebook group of other CF moms or something like CF Peer Connect, or through your clinic, getting set up with someone who might also share those experiences, I think is really crucial. And then just having that whole like team approach, as I mentioned. It was helpful to involve my husband in these conversations. After I came home from the hospital with my daughter, Eloise, I made a very detailed list before I got home of all the medications I was on. I knew I was going to be so tired, and my mom was going to be there helping. My grandparents actually came and helped for a couple of days as well. I wanted them to be able to like look at that list and say, did you do these meds today? Did you no one else helps me with my day-to-day care right now, but at that time, that's what I needed. So kind of having those pieces in place for when I knew I wasn't at my best was helpful to navigate.
Yeah, that's extremely helpful. I hadn't even thought about some of those recommendations you just made. One additional question going off of that is, aside from your care team asking about plans for pregnancy or family planning, what else could we ask to kind of encompass all of the questions that you may have in regards to reproductive health?
That's a really excellent question. Something that I think would have been helpful is starting the conversations earlier, which at the time when I was a younger person with CF, the landscape for pregnancy looked very differently. So I remember the very first time I brought it up with my team, it wasn't a great conversation. It was more like, well, you can get pregnant, so, don't have sex, or, like, just, it was very, I felt kind of like, did I bring up something I shouldn't have? But that was I hoped someday I could be a mom. So I didn't feel a whole lot of comfort with those conversations until about the time when I got married, which is when I would be more serious about starting a family. But I think people generally start thinking about that as they imagine their future. And it does look different with CF, and certainly the landscape has changed fast. But having that openness and comfort. I didn't always know how to start the conversation. So I appreciated my care team bringing it up. And yeah, again, I love that piece about asking open-ended questions, and just in my own like non-CF experience, didn't have a lot of like great open-minded conversations about that in my life otherwise. As a woman, would have really appreciated that from another woman in particular. I feel like that is kind of, at least for me, would receive it differently from a woman or feel more comfortable. So I hope those are helpful.
Yes, thank you. The next question is directed to both Michelle and I. And what are some examples of dose titration? So I can plug in first, and then Michelle certainly add in any additional information you have. But I think both of us probably will start by saying the same thing, as we don't have great answers in terms of specific dose titrations. I do think most centers that I've communicated with do tend to drop that evening ivacaftor dose first, just since we know that is the pill that's probably not adding the most substantial benefit. And then I know we've done the modified hepatic dosing some here at the University of Iowa, switching between 1 and 2 orange tablets in the morning, doing that for a couple weeks and then increasing as able. Once again, everything is going to be dependent on the patient and their side effects that they're experiencing and if they do resolve. Michelle, do you have any more experience?
I think in a couple of scenarios at my center, and then I think I saw this reflected in our listserv at one point, some centers have gone down even as low as just starting with like 1 orange tablet daily and omitting the second orange tablet as well as the evening blue tablet, and doing that for a period of time until recheck proves that patient could potentially tolerate going up. And then then going up to the 2 orange tablets daily, and then adding the blue tablet at nighttime, after a second recheck. And then as far as kind of timeline of like what that looks like, typically it seems like most centers are adjusting on 2 to 4 week intervals. And I think a lot of that just has to do with being able to get the patients to be able to get lab work done and then evaluate those labs and make sure that they're looking okay or in the right direction before advancing.
Excellent. Thank you. Sabrina, I love the idea of you creating a patient handout. And I think it's something that a lot of our patients could find useful, especially as they're navigating parenthood. How would you recommend receiving infant eye exams? Does your center coordinate with like a local pediatric team, or how does that work?
That's a great question. So in Idaho, we have patients that live all over, right? So it's impossible for us to know every pediatrician in Idaho to coordinate with. That's part of the reason why I think having that handout, like you mentioned, is so important, because it'll reach more people and hopefully put them in contact with us. And then the way that we have been trying to help with that eye exam piece of it is for a few patients, we've been able to recommend certain eye exam centers that we know will cover that insurance type. It's not, it's not going to capture everybody, but sometimes just putting in a little work to see what insurances approve what kind of eye centers can help get that first step for patients that are already overwhelmed with all the other responsibilities of motherhood, right? So helping them get the tools to get in is really important. The other thing I'll mention is that there is a service called the 2020 On-Site Eye Exam Mobile Service. They in the past have helped a lot of our patients with getting eye exams done for free for CF patients. And I don't know who all they would reach, but that might be one potential source to look into, because they were super great to work with. And especially for our patients in Idaho, where they live everywhere, it was really nice to have a mobile service that would go out, knows how to take care of patients, look for the things that we're looking for with cataracts, and then report it back as well. So that's probably not the best answer that's going to capture every patient, but I would say the most important thing to do would just have a good way to communicate with the pediatrician. And I think that's probably by the handout.
Yeah, I think that's great. I mean, it certainly is something that has come up in our center, even with our babies that we're starting on modulators. Not a lot of local eye doctors are willing to look in a 4 or 5 month old's eyes. So we're fortunate that we have a peds ophthalmology team, in our clinic, but I imagine that could be a struggle for some, centers. So thank you for sharing. Jillian, back to you. Have you experienced any side effects from Tricafta that you felt like were different from the other modulators? And then if you could just expand more on your personal experience, why Tricafta makes you feel so much better.
Yeah, the biggest difference side effect wise I could talk about is some GI issues. When I first started, I was actually starting to have a little bit more before Tricafta, and then felt that I was having even more afterwards. Now, interestingly, connected to breastfeeding, my daughter Eloise has an issue with eggs and dairy, and since I have cut both of those out because of breastfeeding, those GI issues have really lessened. So I can't say that they were connected to Tricafta for sure, or if they were related to maybe the foods that I was eating. I feel like we're always just kind of guessing and trying something new when it comes to GI stuff. And, alternating, like looking at enzyme dosage was helpful. For me, it was trying to find out what those trigger foods were. I had basically just would fluctuate between having like really bulky stools and then like a lot of diarrhea. And that was, it was like months of trying to figure that out. And working closely with my dietitian to try to troubleshoot that. And then as far as benefits go, not coughing before Tricafta. I would have coughed a lot of times during this talk. And I have a cold right now, so I'm feeling pretty good. I can't really sing the praises of like how well I feel enough because it's just I have a lot more energy. When I first started Tricafta, I had a hard time like sleeping because I just wasn't like exhausted the way I was before. Like I mentioned, being able to like run with my son even when I was pregnant and doing that now. I'm not a runner, but yeah, just like chasing after my kids and having the energy to keep up. To kind of like keep up with the pace of my life in general has been just a testimony of like how well I'm feeling.
I'm sure Simon appreciates that increase in energy. So
yes,
thank
he
you.
does. He demands it in the best way.
Excellent. Michelle, a question for you. There was a comment about a few patients at different centers having issues with their gallbladder removed after starting Tricafta due to either gallstones or other disease. Would you have any correlation between that increased bilirubin and these instances?
It makes me wonder, but I don't really have a good answer myself. I'd have to research it more, but it really does. It makes me think that there could definitely be a correlation there, but I can't say for sure.
Yeah, I think it's interesting because, we talk so much about indirect and direct, and yeah, it makes you wonder if there is something more, we're playing off, the indirect, but maybe there is more issues going on.
Right. And that's why, if we're talking further down the biliary tract with conjugated bilirubin, then I would think that our impact is more on the indirect elevations, and that's what we saw more. So maybe not directly related to that, but then I also wonder if there's impacts further down that pathway.
Like a lot of our discussions, more to come.
Yeah.
Excellent. One of the questions that was posed for me was, and I think I will certainly answer, but I'll open it up to you guys as well, as have I had very many patients transition from triple therapy back to one of the previous modulators? So I've definitely had some hesitancy, especially probably in our pediatric patients that are doing very well. They're really healthy to begin with. They don't have many clinical manifestations of disease. They've never been hospitalized. So that's a hard sell sometimes for parents to switch to something that we say is better, even though we have the data to support it. Their kids are doing fine now. And so I always try to have that conversation of, I would love for you to try this, but I will always keep open the option of switching back if you don't feel like it makes a difference, or if you develop side effects. And I found that to be helpful. I've had very few people take me up on that offer to switch back. But I think being open with patients and saying that that is a possibility gives them a little bit of comfort, because they know that they ultimately have a say in things. If we push them to do something they're not comfortable with, we can prescribe medication all we want, but when they get home, are they actually going to take it? So I have found that to be a very successful approach, and, making sure the patient knows that ultimately they are in control of what their care plan looks like. All right. Sorry, Michelle, I'm gonna throw another one your way. Could you comment anything on the liver elevations being related to alcohol intake?
That's a great comment. We actually had a patient that came into clinic in, I think, early September. And, she got labs after our clinic visit. And she is somebody that had gone off of triple therapy due to, not answering phone calls and being a little bit difficult to get a hold of during the pandemic with some other things going on. And so going back on it, we had decided, we need to probably do the every 3-month monitoring again and kind of act like we're starting over. And lab work came back and her LFTs were, greater than 5 times upper limit of normal. And at the same time, she was definitely having some exacerbation symptoms. So she ended up coming in for a hospital admission. And, we immediately told her as soon as we saw the labs to hold her triple therapy. But then after further discussion of trying to go through and ask some more specific questions about, is she on any new herbal supplements? Is she, what's her alcohol consumption? And then when we asked specifically, more pointed questions about alcohol consumption, it came out that she, the weekend before, had, been binge drinking, which wasn't something she usually did. And so I think that's an important, counseling point and an additional stressor, and something that, if we can have open, honest conversations with our patients and, get a true understanding of what alcohol consumption is and how that can put additional stress on the liver and can potentially cause interruptions in therapy and more frequent monitoring, we can, hopefully prevent those things from happening in the future. But I think alcohol, and especially, binge drinking, which can, people think of binge drinking as like, 20 beers or some really high level, but really for males and females, it's different and doesn't really even have to be that much, can put stress on that liver and cause those elevations. So I think that's a great comment.
No, I appreciated it too. And it's something that, throughout the courses of all of our presentations, we are definitely linking things to triple therapy. And it's a good reminder that we do need to evaluate all of the other possible, confounders as well. And we have a guest moderator that's going to pop in and explain the answer to the question that we did not know. So I think one of the GI physicians in the chat that will help answer the question about the gallstones. So the stone issues are related to existing stones that become symptomatic due to the improved bile flow related to triple therapy use. So the CF stones are not bilirubin stones. So that was the response. So I appreciate that.
Thank you.
All right, let's take a look if there are any other questions coming in. Sabrina, I know you talked just briefly about the Mayflower study, and did you have any timeline on that of, when we'll expect to be seeing more information?
I am not sure. I was hoping for an answer at this meeting.
Excellent. I know there's a lot of sessions, so I agree.
Yes.
All right. A question came in for me about acne. So the question is, the center has had several cases of acne after starting Tricafta. Have there been any new findings to the cause? And I do not have an exact answer of the cause. I know even in our center, in our workroom, we are constantly throwing around different ideas. Some of the theories that we've come up with is just a change in, potentially the composition of the skin, whether that's an improvement in chloride conductance and changing kind of the skin environment. But I don't have a great answer for you besides those couple theories we've been throwing around.
And I know one thing to add, that one of the theories that we've been throwing around too is that even if there's not a direct hormonal correlation that would have been able to link. Does the weight gain itself potentially impact the hormones and kind of increase hormones in some capacity that would be causing the increase in acne too?
Yeah, thanks, Michelle. As you were saying this, I did think of one of my teenage patients that actually commented that now he feels so great after starting Tricafta that he's starting to worry about other things that are important to him. So who knows, that might play a factor as well. You know, these patients who have been sick for a long time are now, you know, able to maintain just a normal life outside of their clinic appointments and hospitalizations. So taking into consideration those other aspects of their life. So I'm going to kind of throw this out to everyone, even though it is adverse effect related. I'm curious, how has everyone in their practice went along with behavioral or kind of the mental health adverse effects that have been recently noted with Tricafta use? And I can start, I guess, first, since it was my topic. We actually do have a psychologist that works specifically with our team. She does see other patients as well, but she has a focus in dealing with chronic disease. And so that has been really helpful. Certainly, we always try to help patients get established locally as well for more consistent care. But we have plenty of patients that she does see on either a monthly or a quarterly basis, just to help deal with a lot of those concerns of having a chronic disease, and especially after starting Tricafta. You know, changes in their future goals, whether that, like Jillian mentioned, is having a family, going back to school, deciding to take on a new occupation. Those are all things that she has been very helpful in navigating.
I can speak to that as well. In our clinic, we see this side effect not infrequently. And one of the things that I like to assess is, you know, diving down into what those specific behaviors are. And then if appropriate, I'm able to triage to our social workers, who are great, by the way. We don't have a psychologist, but we do have them, and they are able to kind of dive in even deeper than I am. Sometimes, though, it comes down to something as simple as lack of sleep. So if they have insomnia, and maybe that's due to, you know, Tricafta, potentially, can we switch around the timing of the doses? And so I'm a big proponent for switching that time of doses if I think they're going to be adherent to taking the nighttime, which would have the orange at that point. And it's been successful in a few patients.
Yeah, and then one thing to kind of add on top of that, kind of going back to, for our pediatric program, we do have a psychologist, and we had a family that had stopped Orkambi in their daughter because of behavioral changes that were observed by parents and by school. And so, you know, they were definitely more hesitant to start triple therapy when approved for the 6 to 11 age range. And so the plan that we came up with was to, well, one, mom was a little bit more open to it because they were doing homeschooling, you know, secondary to the pandemic. And so she felt like she had maybe a little bit more control over, you know, evaluating behaviors and such. And then two, to have our psychologist do kind of a pre and post assessment and kind of do some scoring and evaluation before starting the patient on triple therapy, and then doing a follow-up, you know, at 3 months and seeing how things are going. And that way, mom felt like she could have some more objective data, and then she would also already be tied in with the psychologist. So that if there were concerns, you know, anytime before that 3-month mark, that we would have a resource to and a relationship already established.
Excellent. Thanks, Michelle. One of the next questions that came in was just asking for a little bit more clarification on treating a rash after starting Tricafta. Initially, those studies did show that, you know, it's potentially occurring more in patients with contraception. However, I've definitely had pediatric patients since the age expansion develop a rash. And so I think with a wider range of use, we've definitely been seeing this in patients that aren't necessarily exposed to hormones. But honestly, my treatment is the same. We'll always try to do an oral antihistamine. We've had a couple of cases where we've done steroids just to make them more comfortable. But in all the cases, patients have been able to push through and then continue on triple therapy. Okay, Michelle, one additional question for you. It is kind of a specific question, so I'll try to keep it general here. At what point, do we continue to monitor LFTs? And if they keep increasing, at what point, do we consider backing off on therapy, or do we truly wait for them to hit that threshold for interruption?
Oh gosh, that's such a good question. And it's so patient specific. And I've been through, multiple different scenarios at our center. And, with hepatology referral, often, they'll say, if patient's synthetic liver function is completely normal, then you're fine to go full bore, full dose. And I think that leaves the patient a little bit, and then or parents if it's a pediatric patient, and then the team a little bit unsettled. And so that's where we have then gone to, if we're seeing them consistently fluctuate in the 2 to 3 times upper limit of normal, but we're never seeing that bilirubin bump. So we're really never hitting that, like, you need to stop and discontinue and then reassess point. One, we're going to definitely tie in hepatology if they haven't already been a piece of the conversation. And then 2, I think that might be a point where we try, maybe backing off on the dose and seeing where that gets us. If we back off on the dose, what does that do to the LFTs? And then if the LFTs go down, okay, great. But where are we from a benefit standpoint? Are we still getting benefit from the medication? So that's what we were able to do in that CJ case. And then I think some things that other centers have been doing, which is also really great, is using dose titration. So then backing down and starting at one of those lower doses. So whether that be the 1 orange tablet daily or the 2 orange tablets daily, no evening tablet, and then getting labs and seeing where they're at with that, and then going up and seeing what you can push to, and maybe the liver will adjust over time and you can get up to the full dose, or maybe you find that sweet spot where you're still getting really great benefit from the medication, but you're not seeing all those elevated LFTs.
No, that's great. Thank you. This next question, I will direct it to both Jillian and Sabrina. There's a comment about starting the contraceptive or reproductive health discussions in pediatric clinics. Do either of you have any experience or opinion on that, and if it would be helpful for our care teams to do?
Yeah, I can chime in first. Absolutely, it's super important. And I think leaving this meeting this year, one of the big things I want to work on is incorporating that into our transitions program. So I'll put in a plug for everybody to go watch the transitions pharmacy on-demand session, because it does a great job of outlining tactical ways that you can approach subjects like this with your patients who are under 18. I think it's important. Like Jillian mentioned before, this is something that I think our patients want to be asked about. And maybe they don't come to you with that question, but you should be the one to reach out to them. And I'll let Jillian kind of weigh in as well.
Yeah, I'm just going to follow up right where you left off, Sabrina, that letting your patient know that it's a safe place for that discussion. Maybe you bring it up the first time and it doesn't go great. And you think like, wow, I really bombed that or whatever, but you've effectively let them know that it's a safe place to discuss this if they, want to continue that conversation. And hopefully it can be an ongoing thing, not just, when one time we've covered that, we can check it off. I know I would have appreciated that as well. And I think it's part of that empowerment piece and seeing your patient as a whole person, engaging them in that discussion as well.
Thank you both. I think the take home is starting those conversations early. And obviously it's going to be something that evolves every single time it's brought up. But starting it early, like you mentioned, lets patients know that that is a safe space to discuss. There was a comment about asking from a patient that started Tricafta 3 months ago, and then noticed an increase in drooling and like increased salivation, especially at night. I have not seen this in any of my patients. I'll certainly open it up to the rest of you if you've noticed this, but I have not had anyone discuss this with me yet.
No, I have heard of a lot of sleep disturbances, and potentially that could be related, but nothing specific to drooling.
I have not either, but yeah, I'm going to keep my ears open for that one.
I think that's been one of the most beneficial things, for all the things that patients are telling us, with us exchanging discussions on the listserv and just even mentioning to other CF pharmacists, because all it takes is one person to describe some sort of an adverse effect. And then, the next time someone tells me something, oh, I actually have heard about that. And it's extremely helpful for us. So from a patient's perspective, I would encourage them to definitely share any of those adverse effects, even if they seem mild or minor, with your care team, just so we can cross-reference with other centers in case, it's occurred there. All right. Any other questions? I'm scrolling through here. Michelle, I will, I think you've discussed this definitely throughout your presentation, but if you could just elaborate one more time for a take home, is why exactly does Tricafta increase the risk for liver problems? And then briefly discussing that mechanism one more time.
Sorry, I'll take myself off mute there. Okay, so can you repeat that question? You said briefly.
Sure. So just briefly reiterate why we saw the liver problems with Tricafta, and then what that mechanism is for the liver LFT elevations.
Sure. So I guess just kind of the medication is metabolized or broken down by the liver. And so when that process is occurring, I guess it just puts potential stress on the liver. I don't know if there's anything to elaborate further than that, or if you have any other thoughts on why that's occurring. And I honestly don't have, a perfect understanding of the mechanism for exactly how it's occurring. But I do, just kind of understanding that other medications that can put stress on the liver, or other things such as, alcohol or herbal supplements, those can all potentially be additive, especially if their medications are metabolized through those same pathways or through those same CYP pathways. And so that can overall cause additive stress on the liver and cause those LFT elevations, is the best way I would be able to describe it. But
no, I think that's great. And from certainly all of us can probably appreciate from a pharmacist perspective, just the importance of, making sure we have an accurate understanding of what patients are taking at home in regards to herbal products and supplements, because we know that they can cause a lot of issues with the liver as well. And so making sure we aren't adding to that effect. Yeah. Thanks, Michelle.
Yeah.
All right. And the last question is, are we seeing any elevations in CK levels in our practice, and what are we doing? So we don't routinely check creatinine kinase levels. We have checked a few of them, but to be honest, it's really challenging because we don't have a lot of guidance on what to do if we do see the elevation. And a lot of times we're able to attribute that to something else. I'll open up the floor for the rest of the panel, but yes, we are not routinely seeing it, but we're not also routinely screening for it.
Yeah, I think it may be in a couple of cases where we had patients complain of like muscle pain. We did check levels, and honestly, in those scenarios, I think it was pretty much normal, but that we're not necessarily going out and looking for it on a regular basis.
And we haven't seen that here either.
All right. One additional question came in. I'm not sure if we'll all have time to answer it, but we obviously know the benefits of triple therapy, and it's been so impactful for patients with CF. Have any of you had to have a difficult conversation with patients who are no longer eligible for continuing therapy because of liver disease or because of LFT elevations?
I actually had to have that conversation with a patient, or was part of that conversation with a patient that didn't tolerate tezacaftor, ivacaftor, and had significant LFT elevations, shooting up really quickly into 10 times upper limit of normal. And we tried dose titrations after levels normalized and still, saw that rise. And so we eventually, went back to nothing, but then we're able to then have the conversation later about just going on ivacaftor, because the patient had never been on ivacaftor previously, because they just felt like they were doing pretty well and didn't need it, and were really more of a patient that dealt with sinus symptoms, and that Taz-Iva had really changed their world when it came to sinus symptoms. And so that was a major bummer to then have that experience of them feeling so much better and resolving all their sinus symptoms, only to have to then stop it. And they were ended up tolerating the ivacaftor only component, although they did find that they didn't get as much benefit from it as they did from the Taz-Iva. So that was a hard conversation, because to see somebody feel so great and then have to back off, but then still, talk about how there's continued research and potential opportunity in the future, and that we want to do what's best to keep them healthy long term.
Perfect. Thanks, Michelle. And with that, I believe that we have addressed all of the questions that have been submitted in the chat. Again, I thank all of you for presenting your expertise on the topics, and we look forward to enjoying the rest of NACFC. Thank you.
Thank you.